Pharmacy students, greetings. This is Mike Oldani, and Dr. Albano, I think, does a really good thing in that he asks some of the presenters in his class to do a little voiceover as a review of the slides I went through and the topics we covered a few weeks ago. And I thought that was a lively class. I want to appreciate your interest and participation. And this is a slide I started out with. Bear with me, it takes me a little while to get warmed up. I've been talking a lot the last couple days, so my voice is a little grainy. Excuse me. But like I said that day, boy, if I ever was getting down in my studies as a pharmacist and I needed to be perked up a little bit, there is a carrot at the end of the stick. And really, you've entered a profession that is well compensated when you graduate. And if we look here at just the major health professions and some of the numbers that Dr. Albano put together for you, you see pharmacists are just under physicians. And you're getting that with 6 years of study, 6 to 7, sometimes a little more if you have the undergraduate degree first. But you're compensated well, and I would say justifiably so, because of the expertise you're developing. When we think about the amount of pharmaceuticals prescribed globally, it's approaching $1 trillion probably by 2020, although it may taper off depending on blockbuster models and those kinds of things. You're responsible for a lot, is what I'm trying to say. And if I circle here and look at these professions, and I love this pen, I'll try not to overuse it, you're going to be working with physicians, physician's assistants, nursing, OT, respiratory therapists, social workers. These are all the people that are going to be part of your interprofessional team, which is the theme of this lecture. And I think one thing you should think about when you look at these salaries is salary does not make the expert. So although you are going to be the expert on drugs, granted, you're going to lean on that social worker for a lot. If you work in a context where a social worker is part of your team, you're going to be amazed at the amount of work they do. So hopefully by the end of your time here at Concordia, you'll start to appreciate the roles and responsibilities of some of these other individuals like OTs, PTs, which we have here at Concordia. Everyone has a niche within the healthcare field and within the healthcare market, and looking at compensation gives you a window of how that expertise is valued perhaps by the market, but not necessarily by the healthcare team. And that's the message I wanted to send with this slide. Now, when we look at Concordia's health and social care programs, who are you going to school with here? Well, and I am drinking some coffee, so bear with me. We have nursing, occupational therapy, physical therapy, pharmacy, physician assistant, and social work. And just take a look at the variety of programs and what it requires that we have here. We may have a public health degree sooner than later, thanks to Dr. Albano and some other colleagues he's working with, and we're thinking about optometry, or we have. But we very soon are starting a speech and language pathology program, or I should say speech and language rehabilitation program. Now, some other health professions you should know about are health professionals, the allied health professions, respiratory therapists and so on, athletic trainer we have here at Concordia. We also train students in sonography and as radiology techs. And we also have medical assistants. And I want to stress medical assistants because one thing you probably haven't thought about a lot is you are going to work on a team, at least in some of your clinical rotations. And if you work in ambulatory care or in primary care, you might see how valuable medical assistants have become in terms of creating huddles, early morning huddles in the clinic space with the care team, the health and social care team, to talk about the patients coming in, to help the team administratively with workflow. So these individuals, if we went back to that compensation slide, don't make a lot of money. They are compensated not that well, but their job increasingly has a lot of responsibility in terms of managing the other professionals that are charged with caring for patients. Now, I don't know why that stayed on the screen, but I had a question here. Who is the most important member of the healthcare team? And a lot of you realize that, hey, it's the patient. And when you voted on that, you guys overwhelmingly, I believe, voted for the patient. I'm not quite sure. But that's a trick question in the world of interprofessional education. Because sometimes we're thinking, well, is it the drugs that are being distributed, or is it the doctor making a diagnosis, the nurse who spends the most time, social worker behind the scenes, or these providers that jump in when the doctor isn't available, or maybe they're the main providers. And then, of course, family members, I would put them as a distant second. Or did I say distant? Close second. But clearly the patient is the most important member of the team. And this idea of patient-centered care, where the patient gets value out of the office visit and can feel the value that they have from the providers and the other members of the team, that's very important in the world of interprofessional care, collaboration, and education. So here's some terms to be familiar with: multidisciplinary interprofessional care, IPC, or interprofessional collaboration, IPC again. Patient-centered, I just mentioned. Oops. Interprofessional ed. On campus here, we call it IPE. So no IPE. When you hear that term, you should know what it means moving forward. We're going to have our first program on Tuesday, September 13th from 5 to 7. I'll see you all there. Now, what is the difference between multidisciplinary care and interprofessional care, interprofessional collaboration? And really the big difference is that with multidisciplinary care, you could say conceptually the members of the team are still working in their silos. They're not communicating in a way that would be team-based. They're all working for the good of the patient, but separately. Where interprofessional collaboration is working together in a team-based environment for the good of the patient. And it's the teamwork that's key. So what's the role of the pharmacist in IPC? When I got to lecture, I mentioned, historically it was to serve as the physician's resource. That's one of the sort of cliches of the pharmacist. I'll call him the pharmacist when I have a drug question. And it wasn't until very recently, the last 5 to 10 years, that pharmacists have played a more active role in making medical decisions, helping providers make decisions about prescriptions, helping with medical compliance issues, medical reconciliation, drug histories, and so on and so forth. There are so many pharmaceuticals being prescribed. We are in the era of pharmaceuticalization. If you take one of my courses, Pharma 549, we talk about pharmaceuticalization, that the pharmacist just increasingly and on an everyday basis, has a very important role with medication. Now it mentions here, more recently with high-risk disease states, cancer, geriatric clinics, etc., it's the medical management team that I wanted to stress. That medication management team is very important, and it can be central to so many patients. Obviously cancer patients with chemotherapy, but if we took geriatric patients like Travis Suss, who's our IPE rep for pharmacy, he works at a gero clinic at Frederick. It's all about polypharmacy there. And his responsibility and his team is constantly trying to manage the polypharmacy of patients. And I think I may have mentioned, and I'll allude to it at the end here, he tries to do a lot of de-prescribing. And what you're going to learn as a pharmacist, people love their drugs for the most part. And if they love their drugs, even if they're having side effects or they're not warranted or not needed anymore, it's often hard to de-prescribe them, to get them off the medication. So interdisciplinary care, this is sort of from your text. And what I said was that chapter in your text is to kind of look at it more as an evolution. So you're kind of here. There's some professional awareness of what interdisciplinary care is, what IPE is, and I'm going to stop using this pen. Really sorry, because that just does not look that great. But there's more and more recognition of the importance of IPE. There's more exploration in trial, and that might be at an institutional level, pilot programs, team-based care. That could be by you as an individual seeking out interprofessional education, interprofessional collaborative experiences. It could be, then it sort of evolves into this relationship expansion where hopefully as the different professions see the value of interprofessional care, they commit more and more to creating these kinds of team-based environments in the future. And what's really happening is the healthcare marketplace is often dictating the type of team-based care that's going to be paid for and delivered. And when it's mandated through the market, it's going to come on board pretty quickly. Okay, interprofessional education, what's a nice definition? This is a good one from the World Health Organization. When students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. And interprofessional collaboration is mentioned, as well as teamwork and some of these other concepts and practices I've introduced so far. So one thing you really need to know is this. The 1990s, the Triple Aim, the Institute for Health Improvement, they mandated this idea of the Triple Aim moving forward. They wanted to improve health outcomes and the quality of experience for patients, and they wanted to be more cost effective globally in terms of our healthcare system. Came up with this idea of the Triple Aim, and here's your definition: to improve the health of the population, enhance patient experience of care. And then we start to hear things like quality, access, reliability, service. It's not listed here, but you'll hear that. And reduce or at least control the per capita cost of care. That's the Triple Aim. You should know the Triple Aim. One thing I stressed in the lecture was another book that came out in 1999 from the Institutes of Medicine. It's a very influential organization. It collects a lot of data, a lot of meta-analysis of that data, and they could approximate that between 44,000 and 98,000 people die each year in the United States. Now this is 2000, the last millennium, or the millennium we're in, 2000. That's almost 100,000 people per year possibly that were dying of medical errors. And one of the ways to reduce errors was to introduce the idea of interprofessional collaboration and interprofessional care. And one of the ways you as a pharmacist, might be involved in reducing medical errors and medication errors is by understanding things like polypharmacy, 2 or more medications being prescribed. Of course, there's side effects, and often they're additive when you get into the issue of polypharmacy. So if you take 2 atypical antipsychotics, for example, often their side effects are additive if they're prescribed in the same patient. Of course, drug interactions loom large when you have polypharmacy. You may be asked, because of polypharmacy, to engage in something called drug histories or medicine histories. You might be asked to do that right away as a student on an IPI. Sometimes this is called med reconciliation, and I'm not a practicing pharmacist, but you should have a good definition of med reconciliation as you move into your IPIs, and any practicing pharmacist can help you with that. And usually that's working backwards with the patient, often with their drugs in a baggie, to figure out what the dose is, who prescribed it and when, and if they're taking it. It's very important to help reduce errors by providing accurate med rec recon for providers. Now, medical compliance can increase or decrease with all these factors in mind, especially with the number of medications prescribed. So you may be asked to be part of a med management team that is really trying to improve the compliance of diabetic patients, for example. And as we've mentioned, that IOM report, medical errors often were linked with errors in medical management. The wrong dose, the wrong script was filled, the dose, the medication never made it to the patient, the wrong medication was discontinued. So you're going to be involved in all of these issues, and you'll hopefully work in a team-based environment where you can help people avoid medical errors. And this was just an example of maybe what the role of a pharmacist might be in that context. So this is the symbol or the advertising for the World Health Organization, sort of a very multicultural global view of health, and one, as you notice, of equality. Everyone's at the same level, and we're all connected, and I think that's one of the most important things to think about when it comes to global health. And what I wanted to mention, and I think I stressed this in the lecture, was basically if we look at the interprofessional movement, whether education or collaboration, you could argue it came out of the Institute of Medicine, the Institute for Health Improvement, and the World Health Organization. And specifically, I think you could make the argument that global health played a really important role. And you can look at these books. I recommend reading all of them. This is a great one if you want to learn about Paul Farmer. All these books are by Paul Farmer. He's a medical anthropologist in my field, also an MD, and he started Partners in Health way back in the 1990s. And as you see, 20 years of health and social justice. It really started in a way to manage infectious disease in very poor countries. And what was interesting about the teams they deployed and what they sort of helped usher in when it came to the global health movement were some things you should know. You know that healthcare is a basic human right. There's a need for community healthcare teams on the ground. There's a paradox out there too. The scarcity of doctors created more IPE or interprofessional collaborative opportunities and better outcomes with other health professions, nurses, pharmacists, PAs, aides, community health workers, etc. They were on the ground as teams and communicating about patients and medical compliance and administering therapies for HIV and multi-drug resistant tuberculosis. It was the teamwork that improved medical compliance and patient outcomes. And also, something that's near and dear to me as a medical anthropologist is that culture matters, that you better have some good cultural competency as a healthcare provider, both of your team, because you may have team members that are from different social backgrounds, different class backgrounds, different ethnicities, religions, etc., different gender, different sexual orientations. You should be culturally competent and be able to interact with a variety of people with a variety of backgrounds, both on your team and patients and families that you're going to work with. And that various kinds, and I like this, competencies are required to improve local global health outcomes. And some of them are mentioned here. Culturally competent, so culture, teams, social justice, having competencies in these areas are important as you move forward in your career as a pharmacist. So in 2010, WHO put out the framework of action on interprofessional ed, and it was a series of mandates and protocols. And then this led to the core competencies for interprofessional collaborative practice. We don't want to get too bogged down here, but there's basically 4 domains. And these domains are based around you learning the values and ethics of interprofessional care as it relates to patients. It's for you to understand the roles and responsibilities of the people you're going to work with when it comes to collaborative care. It comes down to a domain of you getting competencies in interprofessional communication, knowing the type of communicator you are and how you work with other communication styles, which incidentally is the theme of our first year program. That's really important for you. So like, I'm outgoing and expressive and amiable and want to make friends with everybody. And that can rub a lot of people the wrong way. Some people just want to get down to business. They want me to get to the point. They want me to stop talking. You can tell I talk a lot. They want me to not be so friendly and just stick to the task at hand. They don't need all the background information. So I have to realize that when I'm running a meeting or when I'm working with a group of diverse individuals, we're not all quite the same. And finally, you need to learn to work as a team. And this is nice. This is the practice domains I just mentioned. So that's a nice summary for you to be familiar with. Communication, teamwork, the values and ethics for the practice you're going to be engaged in, and then roles and responsibilities. So the core competencies, all I want you to know is that here are the original 6. 1, 2, 3, 4, 5, 6. The big 6, 2011. In 2016, wow, sorry, this pen's not working so well. We now have the big 15. So you don't need to know beyond nursing, osteopathic medicine, pharmacy, dental, public health, and medical colleges. They're the original 6. I put social work here because they're a valued member of the team now. They're part of the Big 15, and they're also one of our programs here on campus. But originally it was just these. But this should tell you something. It has more and more value with the accrediting bodies that govern these various specialties. Pharmacy's way ahead of the curve. It's built into our student learning outcomes already, so you should feel happy about that. So we went from 6 to 15. And again, know the 4 domains. Know the 4 domains. And within those are different numbers of competencies. Don't worry about that. Just know these 4 domains moving forward. The types of learners who received interprofessional education, this was from that WHO Global Survey. And a lot of people, well, I shouldn't say a lot, but many professions were receiving some interprofessional ed, but they were saying not enough. So when we talk about like pharmacists here, at that time in the 2000s, about 8% of pharmacists were getting some IPE. Well, our goal here at Concordia for you is 100%. Now, the level is going to vary, but you're at least going to have 4 events that are structured around interprofessional education. Your first one starting Tuesday, September 13th at 5 p.m. Now, over the last decade, some things to know. IP has increased across all health professions. I've made that clear. Curriculum changes are related to IP. Competencies, these competencies are really important, so you'll see curricular, you'll see classes that hopefully you have some other students in, or you'll do an APC lab with nurse practitioners and so on and so forth, or maybe with PAs. There's a report that just came out, another IOM report, 2015, and it states we need more alignment of education and healthcare delivery. This is something called the IPE nexus, where we want you, the learners, mixing more and more interprofessionally with practitioners together at the same site. We need a standardized model for IPE, and we need a stronger evidence base linking IPE to health and systems outcomes. That's really important. So this is what I mentioned, that nexus, and more sustainability. So we're really great at doing the education, but we have to get better at doing that collaborative practice in a concrete way. So you might want to look at some of these reviews. The Cochrane review by Reeves et al., 2011. You can see there's some literature out there, but what we need more of, in summary here, is we need a literature that shows interprofessional collaboration works, it improves outcomes, and it saves money. And those studies are starting to come. You can see here the positive outcome studies, especially in diabetes, et cetera, et cetera. But they did identify 3 gaps. We need more studies looking at IP interventions compared to just siloed interventions. We need more studies with qualitative strands. So that's mixed method. That means talking to more people, getting more narratives. IPE is a little bit data obsessed, but statistical data, and they're looking for more qualitative work, and we need more cost-benefit analysis. So the iron triangle that, this was a slide that Dr. Albano had put in the talk before I added my slides. It's very similar, as you can see, to the triple aim. So this is the iron triangle of healthcare. So really what's always getting stressed is quality, cost, and access. Now, this is making some leaps here because really access and quality, that should improve population health. So what the triple aim was very much interested in as well is improving the health of the individual and thereby the health of populations. So your book also has some of these terms are very important moving forward. They have some terms defined, is what I'm trying to say. So you should look at what quality means and how the Institute of Medicine has defined quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So there are specific definitions by various governing bodies related to terms you're going to come across. Quality. It is standardized in healthcare. Now, these next few slides come directly out of your text, so you can refer to those. Here's some, so there was a slide on quality, cost, and access. And I think for sure Dr. Albano would like you to understand this equation, that value equals benefits over cost. And this is from your text. So I'm going to leave you with here, and this is kind of long, so hopefully you've listened to this in bits and pieces and haven't been bored to death. But in practice, in pharmacy-driven, how can we conclude our discussion on interprofessional ed and interprofessional practice? Well, if we just looked at that topic of polypharmacy in seniors and elderly, okay, if we just look at that, pharmacy can be directly involved in some really good collaborative practices. So you want to identify opportunities where the pharmacist's expertise is essential to driving better team-based outcomes. Seniors in polypharmacy would be one example. You want to link IP to practice through nexus opportunities, learners plus practitioners. If you take most geriatric clinics, they're perfectly ripe for learners like pharmacists, social workers, PAs, doctors to work with practitioners, those students to work with practitioners. That gives you the nexus. And of course, we always want to find practice champions. So if you're interested in interprofessional education and practice, I, as the coordinator of IPE, just as a side note, will help you find what you want to pursue related to IPE on campus and beyond. And then we always want to identify some pilot IP practice sites for where we can do more IPE. So if we look at this Gero clinic that I've been mentioning, this is the one at Fredert where Dr. Suss works on deprescribing. You can read what we're proposing as a study, and I think this is something, if you're interested in, you should talk to us, because maybe we can get you into our research program. But we're going to look at elderly patients that are treated in the sort of siloed model versus the Gero clinic model. We can look at meds versus the electronic medical records. We can document and look retrospectively at who was trained in the clinic team, and so on and so forth. We can measure value. The only thing I'm trying to point out with all this information is that it's a rich site to interrogate what the Cochrane review said were some of the shortcomings out there in the IPE literature, and it's pharmacy driven. So here are just some websites that I had put up for reference. Now, Dr. Albano, he asked some questions. According to the definition of quality, it is intended to increase. You have to look at that. You want to know that answer. According to definition of quality, it is intending to increase. Try and figure out which one it is. Is it health outcomes, predictability, patient satisfaction? That's in your text. Yes, desired health outcomes. The overlap of duties leading to professional conflict might occur between, now if we look at this, start to break down the roles and responsibilities. Different roles, different roles, different roles. These guys are always fighting, and we're trying to get them to work together. Nurse practitioners and physician assistants are both providers, both can do diagnostics, both can prescribe. They might have some professional conflict. This is a great resource for you. This is the University of Minnesota Nexus, IPE.org. I would check it out if you're interested in IPE. This is another great source. Anytime you can get to Canada, I would recommend it. Canada's my, what would I say? If America's 1A, Canada's 1B, I could live there easily. And University of Toronto's an amazing site online. Their Center for Interprofessional Education is a great place for resources. And I think if you wanted to say, oh, should I read one book? Now, all these books are kind of boring and dry, but this is a nice one, Creating the Healthcare Team of the Future. The Canadian team actually comes in, will come to your institution and set up IPE in collaboration over a few week period based on this text. I forgot about this book. I love this book. And if you have time, this should be good bedside reading. And that's a big pun because Teresa Brown was a writer who became a nurse, and this is her memoir. It's kind of riveting. And if you hear her speak, she's always mentioning that nurses invented this idea of the bedside demeanor, taking the bedside with them. And I think all health professions could benefit from that attitude. This is a crazy graph. And when you say, well, is IPC complicated? Yes and no. You need to work as a team, work together. And how we do this, both bureaucratically and through accreditation and evaluation, does get complicated. So I just love these charts. And that's it. So that's a lot of information for you to review. But stick with the big themes that I mentioned throughout these slides, and I think you're going to do just fine on the quiz.